Good morning, everyone, and welcome to our MDT meeting this morning. The idea of these MDT meetings are to combine two subspecialties, talking on one particular topic to try and gain a little bit more about understanding some of these more complex issues. So today we've got cardiology and infectious diseases that are combined, working together. And what we've got is a fellow from cardiology and a fellow from infectious. Maybe just mute the. So we get feedback. So we've got a fellow from cardiology and a fellow from infectious disease. Actually, our new, most newly qualified infectious disease specialists in the country with us today, Tyral and Ramsamy, from the infectious disease side, and then we've got Mohammed Essop from cardiology. So we're going to be talking about infective endocarditis. Each of them are going to give particular aspects of the condition. So I'll hand over to Mohammed.
Is it on? No? Hello. Good morning. It's a pleasure to present on this cold and crisp morning. In the following presentation, I'd like to highlight the enormous impact that echocardiography has made in the diagnosis and management of infective endocarditis since its initial description by William Osler in 1885. At the onset, I wish to emphasize that echocardiography does not place a good clinical judgment. In order to do this, I would like to illustrate a case that was initially seen at Edenvale Hospital and subsequently transferred to CMJAH Cardiology. Mr. FM is a 38-year-old male known with inhalational drug use. He denies intravenous drug use, and he was admitted to Edenvale Hospital with dyspnea. His chest X-ray revealed extensive consolidation, predominantly in the lower zones, particularly of the right lung, with some associated upper blood lobe diversion. He was treated as a multilobar pneumonia, intubated and ventilated for type 1 respiratory failure, and started on empiric tazocin with very little improvement. There was a suspicious soft murmur that was heard in the aortic area, and screening echo performed at Edenvale Hospital revealed a large oscillating mass on the aortic valve and raised the possibility of severe aortic regurgitation. He was started on intravenous Lasix, and there was a substantial improvement both clinically and radiologically. He was then extubated and transferred to CMJAH Cardiology. Clinical examination revealed generalized wasting. He was comfortable on room air. His blood pressure was 110/50 with a wide pulse pressure. His heart rate was 90 beats per minute. It was regular and collapsing. He had digital clubbing, no Osler nodes or Janeway lesions. A Durosia sign was noted. He had a volume-loaded displaced apex beat, a soft aortic heart sound, a long early diastolic murmur with no third heart sound. He had no features of peripheral or pulmonary congestion. His electrocardiogram revealed a sinus tachycardia at 110 beats per minute. He had a normal PR interval, no heart block. He had LVH with a diastolic overload pattern noted by tall T waves in B3, unlike the pressure overload noted in aortic stenosis, where there's LVH with inverted T waves. Biochemistry revealed a normocytic anemia, a normal UNE, an albumin of 28, flat septic markers, HIV and Hep studies were negative. No blood cultures were done on admission prior to antibiotics. However, 10 days later, once infective endocarditis was diagnosed, blood cultures revealed a Klebsiella pneumonia CRE sensitive to meropenem and colistin. Once treated with antibiotics, subsequent blood cultures were all negative. Echocardiography, this is a peristernal long axis view. It reveals a dilated left ventricle measured at 6.8 centimeters at the end of diastole, a dilated left atrium, good contractility, and an oscillating mass noted on the aortic valve that measured 1.2 by 1 centimeters with restricted opening of the mitral valve, responsible for the mid-diastolic rumble, also known as an Austin Flint murmur. This is just a zoomed image of the aortic valve, and one can see the vegetation as well as a flail non-coronary cusp likely. Color across the aortic valve reveals a large area of flow convergence, as well as a large regurgitation jet, effectively occupying the entire left ventricular outflow tract, pointing to severity. In this four-chamber view, the regurgitant jet occupies the entire LV cavity. And a continuous wave Doppler across the aortic regurgitation revealed a triangular-shaped jet with a steep pressure half-time and a dense jet, further signs of severity. The four-chamber view shows no vegetation on the mitral valve. However, there's severe functional mitral regurgitation. And color in the descending aorta reveals hollow diastolic flow reversal with the end diastolic velocity that was measured to be 40. Other features of severity. The right side showed no vegetation, just some moderate tricuspid regurgitation. Discussion. So the Jukes criteria has been around for a while. It was modified in 2023, and it consists of major and minor criteria. The major criteria being blood cultures that are positive for infective endocarditis with typical microorganisms, including strep, staph, E. faecalis, and the HASEC group, or microorganisms that are consistently culture positive, either 2 cultures 12 hours apart, or 3 out of 4 more than 1 hour apart. That's the first criteria. The second criteria is based on imaging, either on transthoracic or transesophageal echo, cardiac CT, or PET scans, or white blood cell scan. Minor criteria includes predisposing conditions such as unrepaired cyanotic heart disease, prosthetic valves, or if there's implantable electric devices or dialysis, as well as features of embolic phenomenon, such as mycotic aneurysms, strokes, conjunctival hemorrhages, Janeway lesions, or immunologic phenomenon in the form of glomerulonephritis, Osler's nose, Roth spots, or microbiological evidence such as positive blood cultures not meeting the above criteria. And the last one is fever being more than 38 degrees. In terms of the classification, it's divided into definite, possible, and rejected. Definite being 2 major criteria, or 1 major and 3 minor criteria, or 1 major and 1 or 2 minor. Possible being one major and 1 or 2 minor, and 3 to 4 minor, and rejected if it doesn't meet any of the above criteria. So what are the indications for echocardiography? Transthoracic echo is indicated if I is suspected based on the Jukes criteria. One would then proceed to transesophageal echo. If the transthoracic echo is negative, but the clinical suspicion remains high, if there's prosthetic valves or an intracardiac device, or if there's poor echo windows. Another indication for transesophageal echo would be if complications are suspected, such as abscesses, fistula, perforation. If there's positive blood cultures with symptoms that would warrant transthoracic echo, or a new murmur with worsening valve function, or fever in high-risk patients that were mentioned above. Or if there's any suspected embolic events such as a stroke or a splenic infarct. So diagnostic imaging modalities, there's transthoracic echo, transesophageal echo, CT angiography, as well as PET scans. Transthoracic echo is advantageous, it's widely available, it's non-invasive, and it's repeatable. Disadvantages would be that it doesn't allow for complete delineation of the left-sided structures, and it may be difficult to pick up local complications such as fistula and abscesses. In terms of sensitivity, it's around 65 to 70% with a high specificity. The sensitivity drops in prosthetic valves to 50%, but the specificity is still quite high. Transesophageal echo allows for excellent visualization of the left-sided structures. It's got good resolution and is good in diagnosing complications. However, the disadvantage is that it's invasive and it requires anesthesia. CT angiography is particularly good at picking up paravalvular complications. However, disadvantages include radiation, it's nephrotoxic, and PET-CT has low sensitivity but very high specificity, and it's generally used in prosthetic valves or infective endocarditis involving implantable electrical devices. What are the surgical indications? So there's three main surgical indications, being heart failure, prevention of systemic embolization, as well as uncontrolled infection. In terms of heart failure, refractory pulmonary edema or cardiogenic shock due to any valvular dysfunction, obstruction, shunt, or fistula, or if you have severe valvular regurgitation or dysfunction with poor hemodynamics. Prevention of systemic embolization, if you have vegetation that's more than 10 millimeters, especially when accompanied by an embolic event, despite being on adequate antibiotic therapy. And the last category is uncontrolled infection. Usually if there's fungal causes, multi-drug resistant organisms, or blood cultures that are persistently positive. This is defined as blood cultures that are positive for more than 7 days, despite appropriate antibiotic therapy. And if there's any form of paravalvular complications, such as abscesses or fistula. Surgical timing, this is divided into three groups. Emergent is usually within 24 hours, urgent is up to 7 days, and elective is more than 7 days. And this is dependent on the presentation of the patient. If a patient presents in heart failure with cardiogenic shock or pulmonary edema, emergency surgery is indicated, and it's a class 1 indication. If there's uncontrolled infection with local complications such as aneurysms, fistula, or an enlarging vegetation, urgent surgery is recommended. And if there's a high risk of embolization or established embolism, and the vegetation is more than 10 millimeters despite antibiotic therapy, urgent surgery is indicated. In terms of the right-sided guidelines, according to the American College of Cardiology as well as the European Society, surgical intervention is reasonable when patients with right heart failure have severe tricuspid regurgitation with a poor response to medical therapy, or if there's difficult to treat organisms such as fungi or multi-drug resistant organisms, and there's a poor response to antibiotic therapy. And lastly, surgical intervention with tricuspid valve vegetations that are more than 2 centimeters in size with septic pulmonary emboli. Those are the general recommendations in terms of right-sided indications for surgery. So I think this is quite an important topic. We often see patients with infective endocarditis and stroke. There's a high embolic risk in patients with established infective endocarditis, ranging between 20 to 50%. The risk of new embolic events once patients are on antibiotic therapy drops to 6 to 21% and gradually falls with time. The current best practice is to offer urgent surgery if a vegetation is more than 10 millimeters and there's no embolism. This is a class 2 indication. The timing of surgery in studies and reports is unknown. One has to balance the risk of embolization that's been mentioned against the risk of hemorrhagic stroke transformation and neurological deterioration. Hemorrhagic stroke transformation portends a poor prognosis with a mortality as high as 40%. Post-surgery, the risk for hemorrhagic transformation on day 1 is 35%. Day 2 to 3 decreases to 15%. After 2 weeks, around 50%. And after 4 weeks, 0.4%. This is offset now by the high risk of recurrent embolization of 50%, the majority occurring in the first 18 days after the initial event. So one has to consult with the infective endocarditis team, which will have a neurologist, and it's taken on a case-by-case basis. Diagnosis and management of infective endocarditis in people who inject drugs. The incidence is rising rapidly over the past decade. Patients present poor long-term outcomes with high risk of reinfection and readmission rates. Unique issues include antibiotic selection and administration, and the indication and ethical issues surrounding surgical intervention, as well as managing the underlying substance use disorder to minimize the risk of reinfection in future. Successful treatment involves a multidisciplinary team to both acute infection as well as managing the addiction to improve both the short and long-term outcomes. So surgical infection in drug-associated IE. So this is just an illustration showing that in persons who inject drugs and have infective endocarditis, the outcomes are worse in blue compared to patients who inject drugs and have other forms of infections and not IE in red. The graph below then shows that patients who inject drugs and have IE and are operated on in red have a higher mortality and a poorer survival than patients with infective endocarditis in blue that are not operated on. So surgery isn't always the answer, and I'll come to why. The aim of surgery is to ultimately eradicate and debride infective tissue and to reconstruct the valve and chamber. Reconstructive material should provide durability as well as low infection rates. And surgery is often complicated, especially in our setting, due to underlying rheumatic heart disease, as well as extensive valve destruction. There's often due to a Staph aureus or fungal sepsis. Bearing that in mind, it requires a skilled surgeon to operate on these cases. However, if one does decide to proceed to surgery, there are various options that can be considered, such as valve replacement. The indication would be for severe valve destruction, heart failure, or prosthetic infective endocarditis. It's a most common choice, especially in South Africa. And then the further decision is whether to use a mechanical and bioprosthetic valve, and that would be based on age, comorbidities, risk of anticoagulation. Valve repair can also be performed. However, it's more technically challenging. There has to be localized infection with preserved leaflets. And when feasible, it is a good option, and it's associated with lower risk of reinfection. If there's aortic root replacement for abscesses, fistula, it can be considered with patches and grafts, as well as annular reconstruction if there's any aortic annular involvement. And this is often done through a repair or prosthetic material. Obviously, if you have an infective device, such as a pacemaker, the treatment is to immediately remove the device and to treat with antibiotics. Generally, right-sided infective endocarditis is managed with a repair as to valve replacement. So in terms of a heart team discussion, the cardiothoracic surgeons felt that in light of the patient's drug habits, a surgical procedure would be futile and therefore decline intervention. It was agreed that if rehabilitation was possible in this patient, a surgical intervention would be reconsidered in future. Thanks.
Just maybe before you, I mean, in this hospital, having been involved in cardiology here for a few years, I mean, what do you find as being the biggest challenges you have with infective endocarditis? Diagnosis or
pregnancy, so I think it starts first with the indication for echo referral. Often patients, there's no application of the Duke's criteria. Anyone with a staph bacteremia, a request for an echo is made. So the indication isn't quite clear on the onset. Then I think the second issue is I think the family as well as a physician involved think that surgery offers
good people.
Offers
good morning. How are you? How was Stephen? It's fine.
And we know that in infective endocarditis that's drug related, at least there's high risk of reinfection. So it requires a multidisciplinary team and often requires a social worker. Often the patients are off the street. Now you're going to replace a valve. The patient can't commit to coming for regular follow-ups, checkups. Oral anticoagulation becomes an issue. So it is quite difficult.
All right.
One needs to ultimately treat
OPT is fine, but I'm going to I have a day at 8. I'm going to court now.
I don't think rushing into surgery is the answer. aside from that, one has to look at the surgical expertise available at the institution. Often these cases are quite complicated, and there is high morbidity and mortality associated with the surgery itself. And surgery isn't always technically feasible. I mean, in the best centers and institutions in the world, that's where those graphs came from. The surgical risk is quite high. Now, if we apply it at a local setting, it can be very challenging. So, yeah, it is tough. I think in patients with infective endocarditis that's, maybe non-drug related, so a prosthesis related, or it is a ICD related, a simple, removal and surgery might help, or if the disease is localized. But often the disease we see is very aggressive. It's usually Staph aureus or fungal, maybe even TB. So there is high risk, and it's quite challenging.
Thank you. I think we'll come back to some more questions and discussion after Tyral. We'll hand over to Tyral. Thanks, Mo, and we'll maybe bring you both together at the end and discuss this a little bit more.
Okay, good morning, everyone. So my talk is titled "What's New in Endocarditis," but we've known what I'm about to show you for the last 2 or 3 years at least, but I'll explain to you why I've included some of what I've done. But just to take a little bit off of what Mohammed Essop just presented, do you think the Klebsiella was the primary cause of the endocarditis? And it's likely now related, yes, but I can assure you that this patient didn't come from home with a dual mutation, NDM OXA48 producing carbapenemase resistant Enterobacterale. So the issue that I want to highlight is that blood cultures weren't done appropriately for that patient who presented with sepsis. And we'll see now why this is an issue. So Mohammed went through the latest ESC Duke's criteria for endocarditis. So I'm going to show you a different one. So this is actually the ISCVID criteria, Duke's criteria. So this came out a little after Duke 2023, and this is the Infectious Diseases Society of America endorsed criteria. So it's slightly different, and why we prefer to use it is because it includes molecular diagnostics, which I'll show you just now. So there's been a few changes that I want to highlight, and importantly, under the pathological criteria, you'll see implantable electronic devices has been highlighted. And any active endocarditis of grafts, or again, CIEDs, or cardiac implantable electronic devices. In terms of the major criteria, so ISCVID has actually removed the 2 cultures 12 hours apart. So you'll see the 12 hours apart clause was removed, and it's actually 2 or more cultures from typical microorganisms, or 3 or more cultures from non-typical or atypical microorganisms. And then I want to show you that under major criteria, again, PCR techniques have been highlighted here, and particularly for Coxiella, Bartonella, and Trophima whippley. Coxiella serology, so IgG phase 1 titers of more than 1:800 has been there since 2015, but you'll see now IFAs for IgM and IgG for Bartonella has also now been included under the major criteria. And then, like Mohammed has shown you, cardiac CT and FDG PET is important new additions. And again, importantly, surgical major criteria has been added, and this is any documented intraoperative finding suspicious of infective endocarditis, which the cardiothoracic surgeons will usually tell you about. In terms of minor criteria, so previous IE is highlighted, again, as well as presence of intravascular devices, and then cerebral and splenic abscesses again highlighted for vascular phenomena. And then again at the bottom, minor criteria PCR techniques together with amplicon or next generation sequencing. And these are not particularly for those microorganisms I showed you earlier. So this is any other microorganisms that you might find on PCR. Okay, so I wanted to talk a little bit about blood culture negative endocarditis, because it seems to be quite a problem, particularly in our setting, and we can actually do things to improve our blood culture yields. But the prevalence for culture negative endocarditis is reported to be between 10 and 30%, 10% perhaps in high income countries and 30% in low income countries. And the most robust data we have is an old study, a prospective 3-year study in the Western Cape that had shown quite a high prevalence of culture negative endocarditis, more than 50% in our setting. And to try and understand why this is, there's a few questions we asked. So are there local unidentified pathogens in a South African setting? Are we having issues with blood sampling? Are we prescribing and administering antibiotics before we actually doing the sampling? And are we not having good access to newer molecular techniques? And to some extent, all of these are true. So the challenges with culture negative endocarditis is, as we know, a higher mortality and a higher rate of surgical complications. And I'll show you a little bit of evidence of this in the next slide. But the other issue is you need to provide empiric antimicrobial therapy for all the likely pathogens. So like Mohammed had said, Enterococci, Staph aureus, and the oral viridans group of streptococci have to be covered under your empiric therapy. And the issue there is that antibiotics don't come without risk, especially the aminoglycosides. So you're going to commit your patient to 6 weeks or less of aminoglycoside therapy, where you could have avoided this by just, isolating the bug by appropriate techniques earlier. The other issue is, again, access to these newer molecular techniques and serology. There may be considerable time delays, especially in the peripheries, with patients being able to get these samples across to a central laboratory for processing. So just very quickly, this is from the Euro-Endo registry, and this was, I think, in 2021, 2022. And just to highlight, the 30-day mortality was proven to be higher in culture negative endocarditis, and the 1-year survival lower for culture negative endocarditis again. So what are the causes? So perhaps one of the most spoken about is prior administration of antibiotics. And this is very, very important. And we've seen even administration of 1 dose of antibiotics in the emergency department can reduce your microbiological yield quite significantly. I mean, we've proven this even outside of endocarditis. In terms of microbiological techniques, whenever we look at laboratory errors, we think of pre-analytical, analytical, post-analytical errors. So we as clinicians are responsible for pre-analytical issues. And this is more to do with how we take the cultures. So we still recommend 3 blood cultures to be taken at least 30 minutes apart from 3 different sites. And there's good reason for this. And it essentially increases your microbiological yield. It reduces your contamination. And then it also gives you a little bit of an idea of whether or not you're dealing with a transient strep viridans bacteremia, which is also common. And that's why we do it 30 minutes apart, because if it is a transient strep viridans bacteremia, you'd hope to clear it by the 2nd culture. So those things are important, as well as sending your cultures to the lab on time. So it's recommended that blood cultures should be sent to the microbiology lab within 2 hours of sample drawing. And I know it's not sometimes feasible in our setting, especially if we use that Perspex box in Ward 20, where we leave blood culture bottles overnight and wait for somebody to come and collect them the next morning. So that's poor technique, and that will definitely reduce our yield, especially if there's exposure to temperature variation, sunlight, and things like that. The other issues with how much volume of blood to draw, and registrars often struggle with how much to draw. And the recommendation is between 10 and 20 mils in each bottle. And why this is because there's a calculated amount of broth inside each bottle. And if you overfill those bottles, if you give more than 20 mils into a bottle, you're going to overwhelm the broth. You're not going to have enough nutrients to support the growth of whatever is there, and your yield may be affected. And likewise, under-inoculating the bottle may also affect your yield. So those things are important for us to correct to improve our yield in the lab. So other causes of culture negative endocarditis could be mural, i.e. fastidious organisms like Haemophilus, the nutritionally variant strep, A. bitrophia, granulocytella, which we do see in our setting, fungal endocarditis, intracellular pathogens. These are like Coxiella and Chlamydia. And then non-infective endocarditis or non-bacterial thrombotic endocarditis that we often see in lupus patients with Liebman-Sachs, or merantic endocarditis that we see in oncology patients. And then lastly, perhaps you have the wrong diagnosis and it's not infective endocarditis to begin with. So what non-culture-based diagnostic techniques do we have available? So we do have serology, and I'll show you the recommendations for serology now. It's relatively inexpensive and accessible. We do have histopathology, but unfortunately, this is only for patients who end up going for cardiothoracic surgery, and those valve tissues are sent off for histopathological analyses. And then PCR. So we do have access to PCR. Yes, it's limited, and I'll explain to you how and when we should be doing it. And then lastly, metagenomic next generation sequencing is something that's more in the pipeline. Yes, we can do it, but there's very little protocols around or guiding us on how to use this for diagnosis. So this is the ESC algorithm. Sorry, the ESC algorithm for diagnosing culture-negative endocarditis. And obviously with any infectious diseases case, especially, the history is important. So you'd have to try and elicit a history of exposure to livestock, cats, parrots, and pigeons. And each of these will give you a risk for a different bug. Then your history should actually guide your serological investigation. So we don't often do serology for all of these bugs in our setting, in our resource limited setting. So we usually use our history to guide us as to what to ask for. But the ESC recommends the Coxiella, Bartonella, Brucella, Mycoplasma, and Aspergillus serology. And that should be followed by a blood PCR and then histology and tissue PCR if the patient is requiring surgical intervention. So in terms of blood PCRs, the yield is a little lower in blood than it is in tissue. So we don't usually recommend a blood PCR for our culture-negative endocarditis case, and this is just to justify the costs. So we would usually do it on tissue. And then lastly, if all else fails, then you should be looking for other causes. So you should be looking for autoimmune disease. And then if you have prosthetic valve endocarditis and it's a bioprosthetic porcine valve, then anti-pork antibodies should also be done. So I'm just going to show you a study. So the links to the study are at the bottom of the screen. But this was a study that was done in the Western Cape in around 2002, 2003. And basically what the study tried to do is to find out what the causes are of culture-negative endocarditis, or the etiology of culture-negative endocarditis. So they had a prospective cohort and a retrospective cohort. And basically they went hard and fast, and they tried to do every possible thing from serology to autoimmune workup, mycobacterial cultures, blood PCRs, tissue PCRs, histopathology to try and look for the underlying causes of culture-negative endocarditis in that setting. And then again, to show you, there was a mortality difference between the two. So we have seen this now in our setting as well. And then to show you the causes, so this was the blood culture positive group. And you can see Staph aureus is the commonest cause, which is in keeping with international data. And then Strep viridans as the second cause, second commonest cause, which is also in keeping with international data. So this was the causes that they found for blood culture negative endocarditis, taking into account all the techniques that they've used. And you can see Bartonella now accounts for 46% in the negative cohort. And then they were still unable to identify in a large proportion of patients, 32% of patients, we weren't still able to identify what the causes were. But when you superimpose this data and you look at all cause of culture negative and culture positive endocarditis, you'll see Staph aureus is still first, but moving in second place is actually Bartonella at 20% and pushing Strep viri down to third. So this is one of our pathology reports. I just wanted to show you how it's reported to us. So we, at Charlotte here, all the tissues that are taken intraoperatively with cardiothoracics are reflexly sent for PCR. Sometimes it's a forgotten request and we go down and we have to request it ourselves. But all tissue that's taken intra-op is sent to micro for a pan-bacterial PCRs. So we have two kinds of PCRs that we use, two types of assays, a pan-bacterial PCR, which is a 16S rRNA PCR, and an 18S rRNA PCR, which is a pan-fungal. You can combine both assays into a pan-pathogen PCR, which includes both the 16S and the 18S. Often we go on risk, and most often the pan-bacterial or 16S rRNA PCR is reflexly done. And this is how the result is reported to us, and it tells us what species was identified, and obviously that will alter our treatment for that particular patient who had been or would have been treated with empiric triple therapy. I put this in there just to remind you about pediculosis humanus corporis, which is the vector for Bartonella Hensley. So my take-home messages, so there has been some modifications to Duke 2023. So importantly, from the ISCVID side, is molecular techniques have been added. And then just to highlight to you that there is quite a high rate of culture-negative endocarditis, particularly in our setting. And we do have improved access to molecular diagnostics. This is done with the private laboratory arrangement. It's quite a quick turnaround time. We usually get results within a week or two. We have to constantly liaise with microbiology because it's sent directly to them and we get the results from them, but it's possible to do. And then lastly, that Bartonella is more common than we think in our setting. Yes, we know that this is Cape Town data. Can we extrapolate that and does it imply that it's true for the rest of the country? And I think so. Anecdotally, with the PCRs that we've seen actually quite a lot of Bartonella. We've seen a few other strange things, but Bartonella has really been on top.